Dr. Ricky Greenwald, welcome to Shrink Wrap Radio.
Thank you.
Yeah, so it's good to have you here. And we're going to be talking about treatments for trauma today. And you've done extensive work on the treatment of trauma. What drew you to specialize in this particular area?
As I was even in college, I just understood unprocessed loss, particularly loss actually, as being the core of, the source of people's problems. And then I learned more about trauma and sort of lumped them together, trauma and loss, as, if you can process those, you grow. And if you can't process them, you get stuck and you're wounded.
Yeah. That was when you were in college. What were you majoring in back then?
Psychology.
Oh, okay. Yeah. So you were thinking about it early on.
Yeah.
Yeah. I have to ask you, were you, did you suffer from trauma of some sort? Was that part of what pulled you in that direction?
I think everybody has. I haven't had a particularly traumatized life, but I've had, things here and there, I think, as most people have.
Yeah, sure.
So I wouldn't say that I was driven by my personal pain or whatever. I was just, okay. I think I was more, my mother's a therapist, and it's sort of, I was the kid in high school that other kids would talk to. So yeah. I sort of knew I was going in that direction for a long time. And as I tried to learn more about it, that was just how I understood pathology and healing, was unprocessed pain versus processed pain.
Yeah. Okay. And I notice you use the term healing, and not everybody who's a therapist uses that term, I don't think.
Well, I wish they would.
Yeah. What does healing, what's everything that carries, that word, for you?
Okay. So going with the idea that when something happens that hurts us, whether it's loss or trauma or some smaller version of those, if you can kind of chew up the bites and digest it, it becomes part of your nutrition, something you grow from.
Oh, that's a nice way to put it.
Yeah. And so we call that processing, right? In psychotherapy language, we call that processing a loss or processing a trauma, where you bring your psychological resources to bear on it. You integrate it into your history, into your psychology. You've created a narrative that's connected with your other narratives. And that's where people grow from adversity. And I think most people have an experience, or many experiences, of growing from things that hurt us. You're a child and you get teased in school or bullied. And if that doesn't happen too much, and if you get adequate support to cope with that, you come out stronger. You learn coping skills. You learn to get over things that upset you. You grow from it. On the other hand, if it occurs in a chronic way and you don't have adequate resources, it becomes an ongoing wound that can have, long-term consequences. So a lot of therapy is focused on coping skills, how to do self-talk or manage your physiological reactions. You look at DBT, mindfulness, yoga, etc. And there's a lot of good methods in there, and I use a lot of those too. However, the limit is that you're managing the symptoms that are caused by your wounds. Whereas when you can actually digest or process, or what I would say, heal from a wound, you don't have to deal with the symptoms anymore because it's not hurting you anymore. Mm-hmm. And so although I value the various coping strategies and I incorporate those into my work, I'm probably most interested in guiding my clients to actually heal from their wounds so that pain isn't driving them anymore.
Yeah.
Now, the technical term for that nowadays is memory reconsolidation.
Right. Yes.
When you take a psychological wound that's kind of stuck in a certain way in your brain, and you reactivate it, you access it, you interact with it in such a way that it can be fully processed and then stored in a different way after that that's more healthy.
Right, right. Yeah, I've interviewed Bruce Ecker
Okay.
about memory reconsolidation. I think I interviewed him 2 or 3 times, and because that's such a powerful concept
Yeah.
uh, that helps us understand a lot. Now, I sort of glossed over your combining loss and trauma, and what would be the link there?
Well, I think for a long time, the field has assumed that loss was one thing and trauma was another. But the research actually doesn't bear that out. And there's been a number of studies over the last decade or so that indicate that, well, here are the 2 main differences according to this research between trauma and loss. One is that with loss, you don't tend to get the heightened startle response, the hyperarousal symptoms that you
Okay.
sometimes get with trauma.
Yeah.
And the other is that other than that, you tend to get more post-traumatic stress symptoms from loss than from other types of trauma. And if you think about somebody who's been through an upsetting breakup, you get the anger, the depression, the intrusive thoughts, it's all there. And so, clinically speaking, I find it useful to consider loss just one more type of trauma rather than as something discrete. Now, every type of trauma has its own twist. You know, if a stranger attacks you, that's different than if a family member attacks you, right? Because
Yeah.
you don't get the betrayal with a stranger that you get with a family member. Every type of trauma has its own twist. But
Mhm.
in terms of how we treat, and you know, grief is like that as well. But in terms of a treatment approach, I find that a trauma treatment approach applies to grief just as it applies to attack from a stranger, just as it applies to attack from a family member. Each specific event and situation has its own nuances, but in terms of clinical impact and in terms of treatment approach, to me, they're much more the same than they are different.
Do we have any neurological evidence about the similarity or dissimilarity?
That's a great question that I can't answer.
Me either. It just popped into my mind that there
Yeah,
might. That's research that somebody else can do, right?
yeah.
Yeah. And you say that we all suffer from trauma. I've had other guests that kind of insist that, well, we're all traumatized to some degree or another, and I guess that it goes on a continuum. But I wonder if there's any danger of overgeneralizing, and in the process, losing something in terms of maybe specificity that's needed for treatment or whatever.
I think different people could argue it different ways. And I won't argue it one way or another. I'll tell you how I do it,
Okay.
which is as a clinician or as a trainer of therapists, um, if there is a psychological wound because some painful experience hasn't been processed or digested, we're going to treat that in a certain way because it's impacting the client, it's driving negative beliefs, it's driving emotional reactivity, it's driving maybe avoidance or whatever. So whether that comes from something that would meet DSM criteria for, you know, criterion A for a traumatic event, it's not that relevant to me as a therapist because the treatment is going to be pretty similar. Now, somebody else who is working in a different way might have a different answer that I wouldn't argue with because for their priorities, it might be
Okay.
more important to
Yeah.
distinguish criterion A traumas from other types of upsetting unprocessed events.
Okay. Okay. You talk about, you sent me a research article that you submitted to a journal, and I found it really fascinating, and it really kind of laid out your work and the justification for it, I think, very clearly. And in that paper, you talk about 3 trauma-specific treatment modalities, one being EMDR, The other one, which stands for eye movement desensitization and reprocessing. It's a good thing they shortened it to
That's right.
EMDR.
Acronyms are good.
Yeah. And one that you call progressive counting that I had not heard of, um, and uh, and then the third one being intensive trauma focused psychotherapy. So I'd like us to move through these, starting with EMDR, and
Okay.
maybe you can kind of describe how the EMDR process is carried out in relation to trauma. Actually, I wasn't clear whether EMDR was developed to target trauma specifically, or at some later point it was discovered to be particularly effective for trauma.
EMDR was developed or discovered, or however you want to call it, in, I believe, 1987 by a psychologist in California named Francine Shapiro.
Who
And,
I have interviewed, by the way.
oh, great,
I,
okay.
I interviewed her back in 2007, and yet enough time has gone by that I need to be re-educated.
Okay. So, yeah, it was originally developed as a treatment for traumatic memories.
Okay.
And it has been applied much more widely to apply to the broad definition of trauma that I've presented today, which
Mm-hmm.
is, in other words, if it's stuck, if it's a wound, if it hasn't been processed, EMDR doesn't care whether it meets criterion A or not.
Yeah, what about anxiety? Would that also fall in that same umbrella or not?
Well, EMDR doesn't target a symptom, right? It
Okay.
targets it targets the wound that may be driving the symptom. So one traumatized person may manifest their traumatization by being anxious or worried about what's going to happen next.
Mm-hmm.
Another traumatized person might manifest their wound by being emotionally reactive with anger to thematically related events or triggers. EMDR doesn't really care about your symptoms. It cares about the unprocessed memory that might be driving the symptoms.
Okay, tell us about the process of doing EMDR. And I'm wondering whether or not it's evolved over time, since it's been, what, about 20 years or more? I forgot what you said.
More than 30 by now.
More than 30 by now.
Yeah.
So I know at one point people were moving a finger back and forth. Then later I heard there was a light box that kind of had the same effect of a flashing light.
Okay.
And maybe it's changed in other ways that I don't know about.
Well, I was trained in 92, so that's pretty early on.
Okay.
Um, and I would say that EMDR has really not changed much in all that time. Now, whether you get we've developed our understanding of it better, and there's certainly been a lot of research, but in terms of the procedure, it's really not changed much. Now, you could always, even in 92, if the client couldn't do eye movements very well, you could apply some other kind of alternating bilateral stimulation is the technical term. Basically, it's a distraction component that occurs at the same time as the client is accessing one piece of the memory.
Mm-hmm.
Um, I'm in the process of conducting a meta-analysis comparing EMDR to other legitimate research-supported trauma therapies. And I'll give you the sneak preview, although we haven't crunched all the numbers yet.
Okay, good.
But from a previous version of this study that didn't get published, I'll tell you what we found. EMDR is at least as effective as the other leading brands. It may be slightly more effective. It might be about the same. That's still not clear.
What are
But,
the other leading brands?
prolonged exposure
Okay,
and variations thereof, basically.
okay, yeah.
EMDR has a lower dropout rate than those other methods. So it's better tolerated. And also EMDR is substantially more efficient. So roughly what you get done in 3 hours of prolonged exposure, you get done in 2 hours of EMDR. Now, there were a few studies in which EMDR was not more efficient than the competitor, and those competitor treatments all had a distraction component like EMDR does. So along with the study of the specific contribution of eye movements, it has become clear that this distraction component access the memory, or at least a piece of the memory, activate it, and at the same time be concentrating on something else. That seems to help people tolerate the memory activation so that they don't get emotionally overwhelmed by it, so that they're able to actually do the processing.
Yeah, yeah. Now, I also thought about tapping therapies, and I suppose that would come under the umbrella of distraction again, right? The same part of the same family?
Possibly, and in fact, one of the studies I'm referring to, EMDR, was compared to emotional freedom therapy, which is,
Yeah,
a spin-off of thought field therapy, one of the tapping therapies.
right.
That was one in which EMDR was not more efficient. So again, the distraction component, and it also had the efficiency advantage that an EMDR has.
Yeah, I've heard claims uh, for the tapping therapies that seem extravagant, sort of one session and the person magically freed up from whatever it was. You can see
I've
that
heard
on,
those
on
claims too, and
YouTube.
I don't know too much about them, so I
Okay.
can't really
Yeah.
address that. I've seen that one study, one pretty well done comparison study out of Scotland, uh, and I haven't seen much else.
Hmm. And you did mention that there was some evolution in the theory of EMDR, some changes there in terms of what was the theory and what has it become?
Okay, I may not be the best person to represent EMDR, but I'll explain it how I understand it. That there are a couple of developments. One is that whereas EMDR was initially tried with clients who had PTSD, it has been applied much more widely, as I mentioned earlier, to any unprocessed memories that are creating psychological wounds and driving symptoms, whether that's major trauma, major loss, an accumulation of individually minor events that has a similar impact, such as, getting bullied every day at school. There may not be a single criterion A trauma in there, but it could cumulatively have a similar impact. So one evolution is that EMDR has been applied to any unprocessed memory that's caused a psychological wound, and it hasn't been limited to PTSD. And then the other evolution has really been in the development of the research and understanding, so that, for example, we used to talk about the eye movements connecting the hemispheres left to right, and that
Hmm.
that was somehow creating the treatment benefit. Well, that was until Gunter and Bodner did a study where they found that this had the same benefit as this did, but
Uh-huh.
this doesn't connect the hemispheres,
Right.
right?
Okay.
And so we've sort of been developing an understanding of what it is, which is why I talked about the distraction component being what
Yeah.
seems to be so
Yeah.
important about the eye movements.
Yeah. Yeah. Fascinating stuff here. And it's fascinating that such a simple experiment could make such an important point.
Well, it was a simple experiment done by people who already knew that this didn't connect the hemispheres because they knew so much about their field.
Yeah. Yeah. Sure. Sure.
Yeah.
Okay. Okay. Well, are we ready to move on to progressive counting, or do you have more
Sure.
that you can say about EMDR?
Well, let's see. What should I say about EMDR? I love EMDR. I've, written books on it and done studies, and um, I use it routinely. I was trained in 92. I used it for about 25 hours last week. You know,
Okay.
EMDR is great.
How does that not get boring for you to do 25 hours of EMDR?
Um, because I see my clients get better.
Okay. Yeah,
And
that's it.
that's what
Yeah,
it's all about.
yeah, yeah.
Um, EMDR is well tolerated. It's been used. I've used it personally down to age 1.5. Um,
Wow.
it's been rather well researched by now, although we can always use more. And the issue with EMDR is that it's a complex treatment approach that's resource intensive to learn and get good at.
Mm.
And so, I'll give a 1-day introductory trauma therapy training to a group of 100 people. And I'll ask, how many of you have been wanting to get trained in EMDR but haven't done it yet? And most of the hands will go up. Everybody knows it's good, but it's
Hmm.
very expensive to get trained. And then even people who get trained aren't always good at it yet. So,
Hmm.
so that's the downside of EMDR, is just that it's a complex treatment.
Where does the complexity come in? Because it certainly sounds simple. Um, what are the subtleties that need to be mastered?
Well, there are two main areas of complexity. One is that the procedure itself has a lot of clinical judgments and choice points. Oh, two main, and now I'm going to give you three. Okay.
Okay, good.
The procedure itself, when you're doing the trauma resolution work with EMDR in a session with a client, there are a lot of choice points and judgment calls, um, and and a lot of steps to the procedure, and a lot of if this, then that. And so it just takes a lot of time to learn how to get good at that. So that now let's back up a step. Which memory do you treat in which order?
Mm.
That's also a fairly nuanced issue. And there's not one standard way of doing that yet. I think there should be. Um, but it's hard to publish research when you have a day job. So, for example, the research we've published on what we call target order, we haven't published it yet. I submitted it. It got, request for revisions. Haven't done the revisions yet.
Yeah.
But I'll tell you how I think it should be done. In general, it's really good to go in chronological order from earliest memories to later ones. The reason is that when earlier memory creates a psychological wound, it's like a sore spot. Another thematically related incident comes along later, which would be this bad already, but it hits the sore spot and it feels like this, right? So if you jump in on, let's say, the precipitating event, the thing that caused the PTSD at age 25, if you just jump in on that with the EMDR, it might go okay, but it could be very difficult for the client because they may have another dozen memories that happened earlier that are underneath that. And so they get not only the bad thing that happened when they were 25, but they're also hitting existing wounds and reacting much more strongly than they would have been if that was a discrete event. And so what we're finding clinically and in preliminary research is that when you go in chronological order, each particular session goes more smoothly because you're only working on that memory and nothing else underneath. And when you get to the big one, clients who tell you up front, I'm not going to be able to face that one. That's just too much. But
Mm.
when they get there, they can do it because they've already cleaned out the stuff underneath. They've got a track record of success with EMDR, and they don't have the sore spot reaction anymore. They only that one event as a standalone, and they get through it. So my belief as a clinician, based on a lot of clinical experience and just a little research, is that in general, it's good to go in chronological order. There are exceptions, but we do get a lot of refugees from other EMDR therapists who use other strategies, and a client just got in too deep and got overwhelmed and wouldn't go back to their therapist. So anyway, there's the procedure itself, which is fairly complex and nuanced. There's which memory do you treat in which order, which really is a great subject for research, and it's a very important element of treatment, and there's not enough research on that. And then there's how to get clients ready to do their trauma work. You don't just meet somebody and say, hi, I'm Dr. Greenwald. What's the worst thing that ever happened to you? Oh, while you're telling me that, follow my fingers. You don't do it that way.
Uh-huh.
There's a lot of stuff that has to happen first. You've
Yeah.
got to build a relationship. You've got to build trust. You've got to help clients identify their goals and emotionally invest in those goals, be willing to work towards their goals so that they're able to do the work in therapy. You've got to help them become, sufficiently stabilized and have adequate coping skills so that when you start working on the trauma memories, if stuff gets activated, that's not going to mess them up so that their life deteriorates, right? So there's all these steps to get clients being ready and willing and able to be successful with EMDR. And this is actually one of my beefs with EMDR training internationally, is that I don't feel that most EMDR trainings adequately train people how to be trauma therapists, how to prepare clients. And that's not specific to EMDR, because I find the same issue in prolonged exposure and a lot of the other leading trauma treatments, is that the trainings tend to be very strong on the technique itself, how to do the trauma work, but tend to sort of assume the therapists already know how to get their clients there.
Yeah, it
And
sounds like it's got a lot in common with what you might call traditional therapies in terms
yeah,
of therapist skills, in terms of
yes.
listening and building rapport, etc.
Yeah, you've still got to be a good therapist.
Yeah,
It's not just a technique, just like you
right.
wouldn't send somebody to a doctor just because they had prescription privileges, right? It's not just a technique. And when you're doing trauma-focused therapy, there's a specific skill set that you've got to have. And so, you know, we're also, my nonprofit organization, the Trauma Institute, is one of the leading trainers of EMDR in the United States. And we spend 2 full days teaching people how to get their clients ready. And we say, go practice that. Go practice explaining to your, taking a trauma history,
Hmm.
explaining to your clients how trauma has impacted them, helping your clients get stabilization skills. Go practice all that. And we give them a month to do that before we teach them how to do this part of EMDR.
Okay. Okay. This has all been very fascinating. I'm glad I asked you to tell us more about EMDR. So now let's move on to progressive counting. Is this a technique that you developed, or that you built on something somebody else developed?
Yes.
Which?
Yes. So progressive counting is based on the counting method developed by Frank Oakberg. I'm not sure if I'm saying his name right. I first read about this in a Journal of Traumatic Stress case study in '96. And he had the client imagine watching a movie in his mind of the memory,
Okay.
beginning to end, while the therapist counted out loud. I think it was either 100 down to 1 or 1 up to 100 or whatever. Now, of course, the client in the case study got better. That's why that case got published. That's how it works.
Yeah.
And I read this thing and I said to myself, that's stupid. And I forgot about it. Until about 10 years later, I was gathering studies comparing EMDR to other methods for this meta-analysis that I still haven't finished 10 years later. And a study had just coming out comparing the counting method to EMDR and to prolonged exposure. It was randomized, blind independent assessment, fidelity ratings, all the bells and whistles. It was a nicely done study. And what they found was, first of all, everybody got better in all the treatment conditions. EMDR, they got better in 6 sessions compared to prolonged exposure. It took them 9 sessions. Okay, that's normal. Counting method, they got better in about 5.5 sessions. I said, wait a minute. This having your client count from 1 to 100 and you're matching EMDR? I got to check this out. So the lead author is down in New Haven. I'm in Massachusetts. It's a 2-hour drive. I went to the website looking for a training. Nothing's listed. So I sent him an email. I want to take one of your training. We got nothing scheduled. All right. Can I see your treatment manual? we're revising it. So I'm interested in this counting method, and I couldn't find out how to do it. So,
So you
so
had to reinvent it for yourself?
so a month or two later, I was in, I was giving a 5-day child trauma therapy workshop at a children's hospital in Safat in northern Israel. And on day 4, normally I would teach a child-modified version of prolonged exposure. I'd been teaching that workshop for years, but I had this counting method on my mind. So I asked the group, hey, do you mind if I teach you something I never tried before? And they said, sure. You know, it's the 4th day, we know each other. I said, all right, but I'm going to change it to make it work for children. Because I thought, you know, a movie of 1 to 100, that's too much exposure at a time for a child. They wouldn't be able to tolerate it. So we started out with 1 to 10. And then the next time 1 to 20, then the next time 1 to 30. So, you know, using my language of digesting bites of the trauma, it gives them a chance to digest something before you do the greater exposure. Anyway, it worked really well. I was kind of surprised. Everybody loved it. They got better on their practice traumas. I had another group the next week somewhere else. I tried it again. It went great. So this counting method, I was really interested in it. A few weeks later, they send me, I got an email, here, we revised our treatment manual, here it is. And this is when I learned how much I had misunderstood and messed up. Because in the real counting method, you guide the client to this 1 to 100 movie, watching their trauma, one time at the beginning of the session. The rest of the session, you guide the client to talk about what happened in the movie and how they reacted to it, which is a lot more like prolonged exposure, which is slower and more difficult for clients. It's more of an ordeal. This is when I started losing sleep. I thought, wait a minute, you know, this 100 seconds of this movie during counting, and you're sort of taking prolonged exposure and getting it to match EMDR. Just by that 100 seconds. What if you just did the movies, which is actually what I had been done in my attempt to replicate the counting method. And so that's how progressive counting got developed. I initially thought I was doing a minor modification, but then realized that by just doing the movies over and over again, it was really a different story than just doing one movie in a session. And so we've done several comparison studies by now with EMDR. I like to compare to EMDR because I see it as the champion among the trauma treatments, because it, you know, I already told you why. So we have a couple of published comparisons in which PC was, had a trend of more efficiency in one and a very strong finding of greater efficiency in the other. We also interviewed the participants in one of the studies and asked them how difficult it was to be a client in that procedure. On the 0 to 10 scale, where 10 is the most difficult and 0 is the most easy, for EMDR, they said 4.4. That was the average, which is great. I mean, for a trauma treatment, that's not bad. And progressive counting was 3.4, even less emotionally intense, even less difficult. We're just crunching numbers now on a larger randomized study, and we're finding no efficiency difference. So I'll tell you how I understand this. This is a discussion I haven't written up yet. I just got the numbers 2 days ago.
Okay.
The studies in which PC seem to be more efficient than EMDR were single incident studies. In other words, treating a single incident trauma. And with EMDR, there's a lot of free association. People are making connections. They're saying, oh yeah, and this memory and that connection, and now it all makes sense. With PC, they tend to stay more in the story.
Mm-hmm.
So when you're doing a single incident, PC is faster. But in the study where I just got the numbers on, this was more of a comprehensive treatment approach where we were working with clients for, 25, 30, 35 hours a piece and working through many or all of their memories, of their trauma memories. And here, I think EMDR caught up because the extra time it took on the earlier memories saved time on the later memories because they'd already gotten some of the work done. That's how I'm understanding the discrepant findings.
Yeah, I was wondering how you decide which technique you'll use with a given person. And is it that if you've got a person who seems to have a very discrete one-time trauma, that you would lean towards the progressive counting?
Well, we've got a couple of different projects where we're randomizing to EMDR versus PC. And what all the clients say is, I'm glad I got randomized to this treatment. So they're both doing really well.
Yeah, right.
I tend to try PC first because it's a little less emotionally intense for clients, and because of my previous impression that it was faster, which I may have to reevaluate pending, I'm going to study these research results in more detail. However, progressive counting, it's structured a bit differently than EMDR. You need a beginning and an ending to this movie you're going to ask your client to watch. And the ending, one way trauma psychologists talk about an unprocessed trauma memory is that it's just a jumble of fragments, images, emotions, beliefs, physical sensations, that it's not a coherent narrative. And so let's say the intrusive, scary image doesn't know that you're safe now because it's just a fragment and it's not connected to the rest of your history, right? And so one thing PC does is it guides the client to identify a beginning of the story before anything bad happened, and an ending of the story when the bad part's over and things are back to normal and things are okay. And that connects the fragment, the scary fragment, to when things are okay again. So now,
Yes, to visualize, to imagine when everything is better.
well, they run through the movie in their mind from the beginning to the ending. So the
Yeah.
scary part's in the middle, but it's connected to the ending. And so it's not just a fragment anymore. It's organized into a coherent narrative where it's connected to the ending.
Okay. But are they imagining a time in the future when they're feeling complete and whole?
Well, that's what I was getting to. Is
Okay.
for some people, it ended the next day. They were fine by the next day. It was over. Things were back to normal. Others have to imagine when they're done with their therapy and have gotten their life back on track, and it's 6 months from now or 5 years from now, to a future ending where things are okay. And we do that sometimes. It's a little tricky, but we do it and it works, except for when it doesn't work. So for example, with people who are severely depressed, some of those people can't picture a good ending that they can believe in enough. So it just doesn't work. And so that's one limitation of PC where I'm more likely to do EMDR, because EMDR doesn't require that sense of when things are okay. Another reason I'll do PC is for a child younger than 5 or 6. I'm sorry, another reason I'll do EMDR is for a child younger than 5 or 6, because PC requires, well, what you're looking for, whether it's EMDR or PC or another method, is a just right amount of distraction. In EMDR, it's the eye movements. In PC, it's the therapist counting out loud. And there seems to be a just right amount of distraction that has the therapeutic effect of enabling the client to stay engaged with the trauma memory, but not get overwhelmed by it so that they're able to do their processing. So if you just have your air conditioner going on in the office, that's not going to be enough distraction to have that effect. If you have a TV going on in your office, that's going to be so much distraction that the client's not going to be able to concentrate on the memory. Now, if you've ever hung around in a first grade classroom, what they do at the beginning of the day is they count to 100 every day, because
Really?
kids are just learning how. Well, first they do it once, and by later through the year, they do it by fives or by tens, right? Kids are learning how to count.
Uh-huh.
A 5-year-old or a 6-year-old, counting takes a lot of attention. And so you might have to adapt the progressive counting procedure so that you're not being too distracting with the counting.
Okay.
And so younger than 5 or 6, I haven't even tried it. And maybe it can be adapted, but I haven't tried it.
Yeah.
Yeah, so I tend to use progressive counting for people with low affect tolerance because it's not as emotionally intense as EMDR. And I just tend to use it quite a lot. But there are plenty of times that EMDR turns out to be a better match. And so in our treatment center, we use both routinely, and mostly whatever you start with is going to work. But now and then you decide the other one's going to work better.
Okay. Well, let's move on to the third one that you talk about and have researched, which is the intensive version of
Oh
trauma.
yeah, yeah.
So tell us about that,
Okay,
where you got that idea from, procedurally, what's involved. And,
okay.
okay.
So imagine you take your car to the shop, and the mechanic says, "Dave, you're driving around on bald tires. That's really not a good idea. One could blow out any time. Tell you what, you come in once a week. Each time I'll change one tire. In a month or so, you'll be good." Crazy, right?
Right.
And yet that's what we do in psychotherapy because it used to make sense to work that way. You know, when you're working on coping skills, things you want people to practice and try out, then come back and talk about it. We'll problem solve. You practice the next thing. The hour per week model is really good for certain things. But if the main event in therapy is healing from psychological wounds, there's nothing about the memory reconsolidation or the trauma healing process that requires that to be chopped up into 50-minute chunks once a week. And so if you ask 100 clients, 100 prospective therapy clients, would you rather get the benefits of your treatment next week or next year? Probably about 98 of them will say next week. I just want to feel better. I just want to do better. And sometimes the costs of waiting are very high. You know, people could end up in jail or losing relationships or jobs or dropping out of school. So, so yeah, we're among the pioneers now in this developing delivery format for therapy.
Yeah.
And we have clients come in and they're working 9 to 5 for consecutive days with their therapist. So for example, I had a client last week. I saw her, I worked with her Monday morning through Friday afternoon, and she did massive amount of work on, childhood stuff and adult stuff. And my very rough estimate, and this has not been tested, is that even using an efficient, effective trauma healing method like EMDR or PC, what would take about a year of therapy in the hour per week format, we get done in about 5 days of intensive. So it's still a lot of work, but it's packed in closer and you can get the results very quickly. It's also more efficient because you're cutting out a lot of stuff that you would normally do in hour per week therapy. For example, when you're meeting a client 1 hour per week for 50 minutes, an hour for 50 minutes,
Mm-hmm.
a quarter to a third of that session is spent with hello and goodbye.
Yeah.
That's
Yeah.
not wrong. You have to do that, right?
Right.
Re-engage, check in, and then at the end, you've got to help the client regain composure, etc. So you have to do that. But in intensive therapy, you don't have to do that. You just keep going. Also, in hour per week therapy, you often, not always, but often have to put a lot of time into stabilization and coping skills so that the client can maintain their current level of functioning while they're waiting for their trauma healing to happen. And again, in intensive therapy, you don't have to do that because their trauma healing is going to happen so quickly that they're not going to need the coping skills because, and I'm citing a particular study here that I don't have the citation in my head, but this was a Dutch study where they randomized a bunch of war refugees to either stabilization interventions or EMDR. So first of all, they didn't get any adverse outcomes from either method. There weren't any dropouts or, whatever. Secondly, they found that people became more stabilized from trauma healing than from so-called stabilization interventions. Because what destabilized them is their traumatization, right? Their overreactivity. And
Yeah.
you're cutting in intensive therapy, you're cutting out the hellos and goodbyes. You're cutting out not all of the coping skill work, but a lot of it. It's kind of like binge watching a season of the TV show. No ads, no recaps, it's just all progress.
Yeah. Right.
So it's very efficient. Now, my rough estimate, and this also has to be tested, and I'm looking for an opportunity to test this because it's a really important question. But my rough estimate at this point is that we're cutting about 50% of total treatment hours by doing it in the intensive format. So it's not only quicker in terms of achieving outcomes, but it's also more efficient. Another benefit we're seeing is that the dropout rates are very low, which makes sense, right? You get childcare, you take a few days off from work, you block out time to do it, you gird yourself to plow through. It's an ordeal, but you get very few dropouts. Our dropout rate is under 5%.
This is making me think about Arthur Janov and primal therapy. You know about his work?
Sure.
And
Sure.
he called it the cure, not a cure, the cure for neurosis. And of course, it involved a lot of emoting, of crying, screaming, and a certain amount of sensory deprivation in a sense. But both approaches share this idea of compacting the time into a very compressed period of time.
Right.
And of course, he made very big claims for that. And people who went through it had a lot of good things to say about it too. So
some did, some didn't.
Some did. Some,
it never really panned out. I'm a researcher as well as a therapist.
Yeah.
And you've probably picked up some of that already, that I'm very clear to say this is my impression versus this is what the research shows.
Right.
And so at this point, there are only one or two studies, maybe just one now, directly comparing intensive to the weekly format. And that study, it wasn't with EMDR or PC, it was with a trauma-focused CBT, a prolonged exposure variant. And that study did find equivalent outcomes. Otherwise, you just have to look at other outcomes reported in the research literature, and they're equivalent. So, and also we're using research-supported methods like EMDR and PC. So, we have the appeal of compacting and getting it done quickly, but we're also really grounded in the research and doing more of it. Yeah.
Right. Now, you mentioned the Child Therapy Institute as part of what you have going on, right?
Yeah, I'm the founder of Trauma Institute and Child Trauma Institute. Kind of a clunky name, but that's what it is.
Okay.
And we provide intensive trauma-focused therapy. We teach EMDR and PC, and we're also researching it.
And what's the difference between working with adults and children? Are there, other than age and so on, what do you find?
Well, I'll give you some generalities. Of course, everybody's different, but in general, adults have had more time to accumulate wounds. So they tend to need more treatment to heal from their wounds. On the other hand, adults tend to have better affect tolerance. And so it's easier for them to understand why they would do something like EMDR or PC. It's a little trickier to get, especially younger children, to understand why they have to hurt for a little while as part of a process towards feeling better. And then I would say the other difference is, of course, the younger the child is, the more actively involved the parent is going to be in the treatment.
Okay. Now you mentioned you do training programs, so a certain number of therapists and wannabe therapists listen to and watch the series. What do you suggest to people who want additional training?
Well, as I mentioned earlier, and I'm not talking behind anybody's back, I've published several papers on this. I have a beef with the way trauma training is often provided, because I feel that, and there's a lot of talent out there providing trauma training, but I feel that the focus is maybe too much on how to do the trauma resolution procedure, whether that's EMDR or prolonged exposure or whatever it is. And you know what, I know the EMDR community best, so I'll speak to that. What we've seen is that a lot of people who get trained in EMDR don't end up using it. And I think a lot of the reason is because they didn't know how to be a trauma therapist and how to get their client ready for EMDR. So I think it's important not only to learn the glory part of the training, like how do you help a client to slay their dragons, but also how do you be a good personal trainer to get your client to be prepared to go into the ring with a dragon and be successful.
Yeah, yeah. I mean, you said the reason why 25 hours of doing EMDR wasn't boring for you was because you were getting such great results.
Yeah.
So I would imagine that the people who drop out somehow, they're not getting those great results, and so they don't stick with it.
Well, one of the things about intensive therapy, I wouldn't say this is the only therapy now. We have a fairly lengthy intake process, not only to figure out which therapists and how many days, but also whether this is even a suitable person for intensive therapy. And not everybody is, because not everybody's able to jump in and start doing their trauma work. And we do some preparation even in the intensive, but not everybody can do that. And so the dropouts are people that we improperly screened, really, who, for the most part, just don't have the psychological capacity at that time to dig in on the trauma work.
Yeah.
So we work really hard to fine tune our screening, because we don't want to inconvenience people, but now and then we don't get it quite right, and in the first day or two we realize we blew it, we made a mistake.
Right.
And it's not always us. Sometimes the client actually didn't tell us important stuff that we asked about, but anyway, that's the dropouts tend to be whoopses where we misunderstood who we were inviting to come to treatment, and over the first day or two we realized this is actually not the right time for this person to be doing this magnitude of work.
Yeah, well, I'm impressed that you take some of the responsibility for for the fact that it didn't work out. Another thing I wanted to ask you about was in the research that you are waiting to find out if they've accepted your article. I think you worked with 61, 63 people, right?
Around that number, yeah.
Yeah, around that number. But you did sort of specialize in a certain kind of trauma, which in this case was people who were victims of crime of various sorts.
Mm-hmm.
And that made me wonder, well, are people who are victims of crime, are they the same as people who have lost limbs in an automobile accident versus people who are in war,
Okay.
etc.?
Yeah. Yeah. And I would go back to what I said earlier. All trauma is the same and all trauma is different. Is that a
Yeah,
paraphrase of Tolstoy? Um,
I don't know. I don't know, Toro.
um, so first of all, victims of crime, most of us are victims of crime. There's child abuse, there's child neglect, there's exposure to domestic violence. There's suicide in the family, there's assault, attacks, on and on. And when you go through that, I would say 9 people out of 10 are victims of crime. So, and we were not only treating that crime event, we were really doing comprehensive treatment, even though the person may have qualified for a particular event, but because we work in chronological order, we might have to do a lot of work to get to that crime event.
Uh-huh.
So I think this was actually a fairly representative sample of moderately to severely distressed clients. I think we didn't do formal diagnoses, but we did trauma symptom inventory and levels of functioning, et cetera. And the scores we got were consistent with an average diagnosis of complex PTSD.
Okay, and what defines complex? What does the word complex add to that?
Okay. So Lenore Tur, many decades ago now, distinguished between single incident trauma versus chronic trauma.
Mm.
And a single incident trauma is you're okay, you're living your life, and then you get in a car accident or you get raped or some one single horrible thing happens and it messes you up and you're traumatized and maybe you have PTSD or maybe you don't have PTSD but other symptoms. So that would be single incident trauma, and that's very easy to treat because a person who was otherwise in good shape and then had that one incident, they tend to be able to engage quickly with the therapist, use the relationship support readily. They have psychological resources. They can just go in, face that memory, work through it, boom, they're done. Whereas somebody with chronic trauma exposure has, especially the earlier developmentally that trauma exposure started, has a whole constellation of symptoms that have sort of been long established and that have become more of a personality style. And so that's going to be a more complex and long treatment because there's more to do. And because it may be harder for, not all, I'm just generalizing here and there's always exceptions, but it may be harder for many people with complex PTSD to engage with their therapist, to trust their therapist, to benefit from the relationship support that helps them to tolerate the pain of working through the memories. So you often have to do more preparation and you have to go in smaller steps. Plus there are more traumas to process. So people with more trauma exposure not only have more memories to process, but they may have had qualitatively different developmental tracks that have created different types of psychological resources or impairments. So it's
Yeah,
a much more challenging kind of treatment.
we're kind of running out of time, but I want to at least give a nod to trauma-induced growth and resilience, and maybe you could just say a few words about where you are with. There's some excitement around that.
I'm in favor of it.
Yeah, right.
And,
Yeah.
you asked me because, that 25 hours of EMDR I did last week, that was in the context of, 32 or 35 hours of total treatment. It's very intense. It's intense for the client. It's intense for me too.
I would think
But
so.
what we see when people do their trauma healing work is that they not only heal from their wounds, but they grow from their experiences and they become much more of themselves because the blocks are kind of cleared out and they have much more chance of developing their potential. And so that's why we have tired but happy therapists in our treatment center, because we are seeing a lot of the post-traumatic growth that comes not merely from experiencing a trauma, but from processing and healing from it and coming out the other side.
Yeah. Well, that's a great wrap up right there. So, Dr. Ricky Greenwald, I want to thank you for being my guest today. Very stimulating.
And I want to thank you for inviting me.